Doctor, thank you very much for your time this morning. I know that you led the trials in Europe over the last year, 18 months or so. I'm just following up on that in this interview, and I wonder if you could tell me a little bit about your role here at University of Ghent Hospital, please.
I started in 1992. I took over from Professor Claessens and have been here working essentially in knee surgery and traumatology as well. And we have several departments that take care of other particular diseases in shoulder, hip, and spine, and hand surgery and pediatrics. So I run a little bit the knee clinic, if you could say so.
It is the knee we're here to talk about today. I wonder if you could tell us a little bit about the meniscus and a meniscus tear. What is it?
Well, this is a long time issue. It's a cartilage, a semilunar cartilage that seems to be very important in distributing the load in the knee joint. When I was in training, we removed all these things, and most of the time things went well. However, we saw that over time, a number of knee joints disintegrated, degenerated because of the meniscus had been removed, probably because sometimes there was some axial deviation, maybe because there was some overweight, maybe because these people did too much. Usually everything goes well when you remove a piece of the meniscus, but sometimes the knee is the culprit and then things go wrong, and we need something to fill in that gap for these patients.
So how does a meniscus tear actually occur?
It's related to overload and a twisting injury. Very often the foot is locked into the ground by doing one or other maneuver, and then the body goes the other way and it twists and it tears, and usually it tears where the meniscus is weak. So once you get a little bit older, it tears easier than it is torn in a young individual, even though these young individuals, when they do sports like football here in Europe or rugby, these tears are complete, and then you have to remove quite a bit of the meniscus. And so that's also an indication to think about avoiding degeneration and do something about this.
Is this an injury that affects more men than women?
It is, I would say, more in men than in women. Shall we say that men are a little bit more physical as you take it overall in the working force. Ladies are a little bit more gentle, but nevertheless we see also ladies who are doing sports like football and then ruder sports, and they get injured as well.
Okay. So when the meniscus is damaged, what further damage occurs?
When you remove a piece and then remove like a buffer in between the femur, the thigh, and the tibia, the leg, and the cartilage has to wear this, it's overloaded. And if these people go on with sports, with overload, and if there are a little bit of axial deviation, then they break down their cartilage more than if the meniscus was still present. So in these particular cases, one may do something to replace this tissue that is missing.
You pioneered Actifit in Europe. How have things progressed over the last year to 18 months?
Well, we've been very strict with the indications. It was not very easy because we think very highly of this product, but you have to keep to very strict indications to find out whether or not it will help. And as we went over the cases with several good surgeons all over Europe, we feel that the pain has been relieved in the majority of cases. Very well, because that is always the reason why patients come to you. It hurts, doctor, and you should do something about this. And I think we've had very good results in that respect, for sure.
Okay. What's Actifit like to work with?
I would say it's an easy product to deal with. It's a strong product. This polyurethane substance looks and feels a little bit like cartilage. Of course, it is nothing to do with cartilage, but it's something that will allow the body to grow in and form a tissue that is as strong as the meniscus over time. And that is what we expect from it. But nevertheless, as you insert it, it's still polyurethane the first 6 to 1 year almost. And so you have to have a strong tissue that will kind of immediately allow people to weight bear on this and be active again. You cannot have them 1 year out of a job because of that. So you need strong tissue and tissue that allows for our cells to grow into, and that's important.
When is it a suitable solution?
When it is a suitable solution, it is when you have a partial meniscectomy and when people have pain. And it's very important that we should not use it in every resected meniscus, because most of the time these partial meniscectomies will evolve well if people are a little bit careful. But if pain starts, say after 6 months, when patients still have pain or are invalidated, then we have a good indication for inserting and using these new products like Actifit.
Okay. Have you found any problems with the implant at all?
We haven't found not really problems with the issue, but surgery sometimes is tricky. The surgery is, you have to operate sometimes in huge knees and in tight knees, in unstable knees that you have to stabilize after that. So it's not always an easy surgery. It seems like just inserting a piece of tissue, but it's not always so easy. So you need some experience, not only for the indication, but also for inserting it. But it hasn't harmed people at all.
What do you feel are the main benefits of Actifit?
The main benefits is that you have a solution in situations where you did not have a solution earlier. In these partial meniscectomized knees, with patients being active, they cannot go back to work, they cannot play sports. And now, potentially, we have a solution for helping them with not an easy surgery, but not a very aggressive surgery, replace what is missing with arguments that for the future it will replace the meniscus and have these people go on for a number of years. Like right now, we would have to say refrain from being active, refrain from doing sports. And today, in 21st century, is not really something that you just tell your patients and they will not accept it.
So is this a lifetime solution for patients?
I do not know if it is a lifetime solution. Of course, we have no crystal ball in that respect, but it could be. But we're not very sure because, of course, if you replace a meniscus and say it's healed, then people do crazy things again, and they may tear it again, like they would tear their meniscus on the other knee. So you're never sure. You let them do again things that may hurt their knees, but that's not a reason for not trying to having them in better shape.
Has the procedure changed much since you started the trial to where we are today?
Well, we know where the tricks and the tips are now, and the little problems. Sometimes it's tricky to do that in a very tight knee, so we know we have to release a little bit of the ligament. For instance, we know that you could do that in association with an unstable knee joint, but then again, it's very difficult to insert it. So maybe you should do the surgery step by step, first stabilize and then do the meniscus. So we've learned that day by day, and so as we can share these tips in the surgical world and with the colleagues that have been doing this surgery as well, it's improving and becoming easier, which is for the benefit of the patient.
What about the rehabilitation? How's that changed?
Well, as I recall, the experience we have of 20 years now with meniscal transplants, I remember the first cases is we put them in plaster for 6 weeks just to make sure that nothing would go wrong with all the problems that an immobilization may do rise. And we're very strict. We've been very strict in the study with the Actifit, but I think we may loosen up and be less tight on these instructions in rehabilitation. Not that they can wait beer or go back to sports earlier. That did not change, but we are not so strict on immobilization, and patients like that, and we start to like that too.
Would you say that Actifit is a success?
I'm sure that it is a success. But surgery is indication. We should not forget that. And if you have a good indication and you have a good product, then you have very many chances that you have a good result. But if you use it just blindly in all cases without reflecting to a good indication, then your surgery will be average, with average successes. And we have to be fair to our patients, fair to the economy, because that is an expensive thing as well. It's surgery. And we should not overact in the indication. So keep very low, until you know better, and that will be for the benefit of our patients indeed.
Dr. Verdonk, thank you very much for your time this morning.